3, 2.
Yeah. So good evening, sir. First of all, let me introduce our esteemed speaker, Dr. Vivek Tiwari, sir. Dr. Vivek Tiwari, he is a renowned medical oncologist in Bhopal city, and he is a associate professor at Gandhi Medical College. And Dr. Vivek Tiwari, sir, has completed his education in MD radiotherapy and DNB from medical oncology from Manipal, Bangalore. So, Dr. Vivek Tiwari has extensive experience in managing all the spectrum of cancers. So, today, Dr. Tiwari will be sharing a valuable perspective on darolutamides. Over to you, sir. Please.
Thank you very much, Deepak, for the kind introduction, and I thank Bayer for providing me this platform to discuss a very interesting new breakthrough that has come up with this molecule, darolutamide. So, before I start with my presentation, I would like to say about 10-15 years back, we used to consider prostate cancers as a Western disease and not so much in the Indian subcontinent. But over the past couple of years, we have seen the incidence go up in the Indian context, and very often we are getting to see prostate cancer patients, and unfortunately, most of these patients are in the metastatic setting in the at presentation. So that is where the role of this particular molecule comes in. So today we are discussing darolutamide and the Aeronaut study, which has put itself as the new benchmark in metastatic hormone-sensitive prostate cancers. It's not moving. Yeah. So these are my disclosures. Thank you again, Bayer, for providing the slides and the platform. So, how has the treatment paradigm been over the past couple of so many years, starting from 2014 when we had the pivotal Charted study, which provided the role of docetaxel along with androgen deprivation therapy. Then we had a platform trial by the name Stampede, in which the arm C again pivoted the position of docetaxel plus ADT. Then came the era of androgen receptor pathway inhibitors by abiraterone, the Latitude study showing its results. Then Stampede arm G again proved the same results, abiraterone along with ADT. Then we had enzalutamide with Arches study and Enzamet study. We also had apalutamide by the way of Titan study. But then around 2021, we had a new revolution in the treatment of metastatic prostate cancers with the advent of a triplet therapy, that is adding chemotherapy, androgen receptor pathway inhibitors, and ADT. So we had one study which used abiraterone plus ADT plus minus docetaxel, and a very important study by the name ARASENS, which used darolutamide plus ADT plus docetaxel. So there were some subtle but important differences between these two triplet studies, wherein the patient population that was taken in ARASENS was de novo metastatic. It was high volume disease, and then this study showed an OS benefit with the hazard ratio of 0.68. And as we talk today, we have the Aeronaut study, which is showing very optimistic and positive results with the use of darolutamide and ADT. And we also have ARASEX study, which is there in the pipeline. So the reason for all these advents is that despite treatment with androgen receptor pathway inhibitor and ADT or docetaxel plus ADT, there's a large population of patients, especially the hormone-sensitive metastatic prostate cancers, who tend to progress to metastatic castrate-resistant prostate cancers within 3 years, which is not good with respect to the disease biology, the way patients have to suffer, and how the treatment paradigm goes up. So this is the unmet need, which forces us to look for an efficacious treatment, which is able to provide us a better safety profile with the patients of metastatic hormone-sensitive prostate cancers, which is not adding major toxicities, which is having a low drug-drug interaction potential. So based on these ideology, the ARASENS study which has shown beneficial efficacy and safety profile in this subgroup of patients, has led to its approval in India in 2023. So, as we will see in the upcoming slides, the detailed analysis of this trial, that darolutamide along with ADT has proven to provide efficacy benefit with a favorable safety profile in metastatic hormone-sensitive prostate cancer patients. And we'll be discussing the ARANOTE data and the nuances of that. And with the data that we're about to see, by the end of this presentation, I believe we will be uh, looking at darolutamide more optimistically with the kind of potential it has to change the treatment paradigm. And another thing that it would be the only androgen receptor inhibitor which can be used with and without chemotherapy. With chemotherapy, we have the data of ARANOTE, and without chemotherapy, with chemotherapy, ARASENS, and with chemotherapy, ARANOTE, we'll just be discussing. So, a little bit into the background of treatment. So, darolutamide plus ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancers, the ARASENS study, which showed daro plus ADT and docetaxel demonstrated favorable efficacy and safety versus ADT plus docetaxel. So, as I told you, the showed an overall survival benefit with an hazard of 0.68. So similarly, on this going on the same thought process, ARANOTE study was designed to evaluate whether or not Daro plus ADT versus ADT would be able to provide us with a new treatment option, which is without chemotherapy in the space of metastatic hormone-sensitive prostate cancers. So this is a brief overview of the study. It is a randomized phase 3 study, double blind phase until primary analysis. It enrolled a healthy 6,665 patients of metastatic hormone-sensitive prostate cancers, confirmed adenocarcinomas, and with a PS 0 to 2. The patients were stratified on the basis of visceral metastasis and whether or not received prior local therapy. So the randomization was 2:1 towards the Daro versus the placebo group. And darolutamide was given 600 mg BD along with ADT, and the other group had placebo with plus ADT. The primary endpoint, as with all the trials of prostate cancers, was radiological PFS, but the key important secondary endpoints were overall survival, time to initiation of subsequent antineoplastic therapy, time to castrate-resistant prostate cancer, time to PSA progression, rates of undetectable PSA, something which was seen, I would say, for the very first time in this trial, time to pain progression, looking at how the patient is doing subjectively, of course, the safety profiles. So, and at the end of the primary analysis, 100% crossover was allowed to the Daro arm. And in that arm, the selected endpoints were overall survival and safety. So these are the demographic and clinical characteristics at baseline for the both the groups. If you see, one interesting point is that in this trial, there was a sizable chunk of the Asian population. If you see, 32.3% of Asian population, along with other, it was a multi-continental study. We had all the races, but we had a significant inclusion of the Asian population as well. Then, looking at the metastasis at initial diagnosis, the de novo metastatic disease was 71% in the Daro arm, 75% in the placebo arm. So all the factors, the characteristics were well balanced with respect to age, race, region, performance status, a de novo or a recurrent disease, the disease volume being high or low. Just to remind you, a high disease volume is considered to be a visceral metastasis along with a bone metastasis, or at least 4 bone metastasis, in which one metastasis should be outside the axial skeleton. That is how we define the high risk disease. So all these factors were well matched between the two arms. If you look at country-wise, the other trials which have happened, so looking at the third photo, the ARANOTE trial, we see a very sizable and a very respectable representation of the Asia Pacific region. We had Chinese patients, we had 13.7% of Indian patients. So that is what makes this data very relevant to us as we discuss it today. So the primary endpoint of radiological progression-free survival, if we see, 70.3% patients versus 52.1% patients achieved radiological progression-free survival with a very healthy hazard of 0.54 and a significant p-value. Median follow-up in the darolutamide group was 25.3 months, almost 2 years, and closely 25 months with the placebo arm. Just a sec. So looking across the subgroups, the forest plot analysis, we see all the subgroups favoring the darolutamide with respect to the age, the baseline PSA values, the Gleason score, the disease volume, whether it was high or low volume, the race, and whether whatever geographic region we look at, visceral metastasis presence or absence of that, and a prior local therapy. All the subgroups that were predefined showed a positive impact of adding darolutamide, especially the high volume disease. You see, I can't point it, but it is showing a very significant impact with the addition of darolutamide. So looking at the key secondary endpoints, the overall survival, it was not reachable with the darolutamide arm versus 26.9% patients had passed away in the placebo arm. Time to conversion from a castrate sensitive to castrate resistant disease was again 34.5% patients in the daro arm versus 64, almost double patients in the placebo arm. Time to PSA progression, again, the time to initiation of subsequent systemic therapy for prostate cancers, all, and the time to pain progression, which is a very subjective and a very relevant factor with respect to patient satisfaction and patient clinical well-being. So all these arms were very were beneficial towards the darolutamide. So when the primary analysis was conducted, the OS data was immature. So patients are still being followed up. We'll be coming up with the updated data for a better understanding. But all these factors, which are very important from the disease biology point of view and the patient well-being point of view, favor darolutamide. Looking at the time to conversion from castrate sensitive to a castrate resistant condition. So we see a hazard of 0.40 along with the use of darolutamide. The median was not reached. And the time to pain progression was also very significantly, and with the hazard of 0.72. And as I was mentioning, the delays in time to pain progression is of very utmost importance to the patients, and it has not been demonstrated with other androgen receptor pathway inhibitors to date. So this is something taking the patient's perspective into a scientific manner and addressing that. Getting to a PSA of less than 0.2 nanogram per ml at any time during treatment. So 62.6% of patients in the darolutamide arm had a PSA less than 0.2 nanogram per ml at any time during treatment, as compared to only 18.5% patients in the placebo arm. Also, the time to PSA progression not reached with darolutamide, and 16.8 months with placebo plus ADT as a ratio of 0.31. So we can conclude that. Sorry, I'll just have to go back. Just a sec. So with this hazard ratios, we can be very confidently saying that 63% of patients in the darolutamide arm attained a PSA of less than 0.2 nanogram per ml, and this represented a 69% improvement, a hazard of 0.31 in the time to PSA progression in the daro arm versus the ADT arm. Also, looking at the high volume and low volume disease, we see this graph uh, at different time frames. Uh, Darolutamide having a higher potential of response with the high volume disease as well as the low volume disease. The impact is much more in low volume disease, but again, in high volume also the difference is quite significant. And subsequent life prolonging anti-cancer therapy. Once the patient has progressed on whatever arm it was, so patients with subsequent life prolonging systemic antineoplastic therapy, 32.5% patients required in the darolutamide arm versus 42.5% patients in the placebo arm. The subsequent therapies which were predefined could be docetaxel, abiraterone, enza, APA, cabazitaxel, PRRT with radium, or olaparib in the BRCA mutated patients. So, looking at the adverse events, so with the Daro arm, any adverse events was 91 percent versus 90% in the placebo arm. Grade 3 or 4 were also similar in both the arms, 30%. Grade 5 was a slightly lesser, although not statistically very significant, but at par with the placebo arm. And serious adverse events were also similar in both the groups. And which led to permanent discontinuation of darolutamide was 6.1% in the darolutamide arm versus 9% in the placebo arm. And the median treatment duration was roughly 2 years in the darolutamide arm versus 17.3 months in the placebo arm. And the safety profile which was observed in the darolutamide in this particular trial, ARA note, was independent of PSA response and was consistent with the favorable tolerability which was seen in the RMS and the ARASENS trials. Most common adverse events which are encountered with darolutamide is fatigue, which was definitely more than the placebo arm. Along with that, other side effects which we always expect with this kind of treatment are some form of anemia, arthralgia. Rash is something which is a little more bothersome with the use of apalutamide. Otherwise, some liver function dysfunctions and some GI dysfunctions are like expected and well not very bothersome. So mainly it was fatigue. Then again, practically speaking, rash is becomes a little worrisome on occasions, and then we need to monitor the liver functions uh, when the patient is on this particular drug. Again, comparing that, the adverse events which are commonly associated with overall androgen receptor pathway inhibitors, whether it may be abiraterone or enzalutamide or darolutamide or apalutamide, is hypertension, vasodilation, flushing. This is all the mechanism of action of these particular drugs. Some form of diabetes mellitus, cardiac arrhythmias, fatigue happens with all the drugs. A little more with this rash, as I was mentioning. Some rare vague incidences of bone fractures, weight loss, mental impairment disorders. These drugs do have the potential to pass through the blood-brain barrier. So some cognitive or some neurological effects are seen, and they do happen actually. Some mood disorders. So these are the basic side effects which are common with all the androgen receptor pathway inhibitors. However, darolutamide does not show a very higher chances of this happening. So this abstract was presented in ASCO 2025 last year, wherein looking at the FACT-P, the functional assessment of cancer treatment prostate. So darolutamide extended median time to deterioration in the functional assessment of cancer treatment prostate total score by 5.1 months versus placebo. It happens to be the first and only androgen receptor inhibitor which has demonstrated clinically meaningful delays in pain progression and overall well-being. After all these data, after all the studies, our first priority, our first responsibility lies towards the patient. If our patient is benefiting with respect to pain progression and overall well-being, I would say that is a good thing to have. Again, on the other parameters of overall well-being, whether it is social, whether it is functional, whether it is with respect to urinary symptoms, we see darolutamide performing uh, social family well-being events at par with the placebo arm, functional well-being, uh, urinary symptoms being less as compared to placebo arm. So all in all, for a good response, a well-tolerated drug, a drug which is helping the disease biology and the patient well-being. I was like, this seems to be a very good data. So just to conclude, uh, darolutamide plus ADT, as we just witnessed in all these slides, significantly improved the radiological. Sorry, something happened. Sorry. I'm sorry, something. Let's just. Uh, Deepak, can you put the conclusion slide? Something is happening to my system.
Sure, sir. Just give me a minute.
The last slide, please.
Yeah.
The conclusion slide. Yeah. Yeah. Can you just enlarge it, please? Yeah, that'll do. Thankfully, आखिरी में ही हुआ.
Yeah.
So just to conclude, darolutamide plus ADT significantly improved the radiological PFS in patients with metastatic hormone-sensitive prostate cancers. Darolutamide showed a benefit across all secondary endpoints, be it OS, be it PSA, the time to progression, the high volume disease, the low volume disease. Also, darolutamide was associated with a deep PSA response regardless of the baseline PSA. We saw a healthy 61% of patients being at a value of less than 0.2 nanogram per ml. And darolutamide is the first and the only androgen receptor inhibitor to have demonstrated clinically meaningful delays in pain progression and overall well-being, which included social and family well-being, a functional well-being, urinary symptoms, and with a favorable safety profile. So, darolutamide plus ADT without the addition of chemotherapy does have the potential, as backed by the robust data, to become an additional standard of care in the patients who are metastatic hormone sensitive prostate cancers. So, next slide, please. So,
Yes, sir.
I have a lot of.
Yeah, actually, sir, there are a few questions in chat box, sir.
Yes.
Yes, the first
Voice
question
is
is
not
how,
properly
yeah,
audible.
yeah, yeah.
Important.
Shall
Yes.
I shall I read for you?
Yeah, I'm able to read. So
Okay.
this question, how important are comorbidities, concomitant medications, and tolerability when selecting an ARPI? A very relevant and a very practical questions. Practical question. So, all the androgen receptor prostate inhibitors have some degree of liver dysfunctions, and enzalutamide in particular, the most having chances of seizure. So any CNS comorbidity. In such patients, we should avoid using enzalutamide. At the same time, abiraterone is prone to cause more of blood sugar ups and downs. Also, abiraterone has to be taken with a steroid, so that is a concern. With this darolutamide, also we have some CNS penetration and those effects, but I would by how I select is that if a patient is like very elderly, not being able, not in a very good position, and having any prior history of a seizure or any CNS comorbidity, I tend to avoid especially enzalutamide. And all these elderly patients have some form of comorbidity in the form of blood pressure or diabetes, which is very common in our country. So that is how we should be choosing. There is no one size fits all. Each drug has its supporting data, but we have to look at the patient and select accordingly. And so Abhishek asks how pain was evaluated, visceral or body pain, comments on use of bone directed therapy. So pain was evaluated, Abhishek, pain was evaluated using the standard pain scale, which we use, the URTC pain scale, and the use of local therapy. Uh, can we get back to the chat box? I think when we are Yeah, so pain was evaluated with the standard URTC questionnaire and use of bone-directed therapy. Bone-directed therapy in hormone-sensitive prostate cancers is a very a little controversial topic. So for castrate-resistant prostate cancers, so we routinely mm, offer bone-directed therapies. However, with hormone-sensitive prostate cancer, there's always a risk of flare-up. So unless and until we have a very strong reason to offer bone directed therapy, it is not given on a routine basis in hormone sensitive. So any other question or comment by any of the members, please?
I think, sir, all the question has been answered wonderful by you, sir. And thank you for your valuable time and valuable perspective on dialytomide, sir.
Thank you. Thank you so much, Deepak. Thank you, Bear, again. And thank you all the participants. It was a pleasure to discuss this trial with you all. Thank you so much. Good
Thank
night,
you,
Thank you.
sir.
everyone.
It's a good
Good night.
presentation. Thank you, sir.
Good night, everyone.
Good
So
night.
I request technical team to close the session. Thank you, sir. You can log out, sir. No issue.
Okay. Thank you.
Okay.
Bye.